few words about myself for those of you who don't know me. I'm working with EHTEL since a bit more than 2 years now. But previously I've been working within the Ministry of Health, the Public Federal Service, as we call it in Belgium, driving the Belgian e-health roadmap. And leading a number of projects, foundational projects in Belgium. But today, I would try to present you a bit how the question of the shared medication records has been evolving in Belgium. And continuing also, and that's why I would take just 2 or 3 minutes just to tell you about Belgium, because you might all know about Belgium, but you might not know how complex the country is. It's a small country, a bit more than 11 million inhabitants, but with 3 different languages, German, French, and Dutch, and 5 governments, basically, which have health as a competence. So the health domain is shared between many ministers in Belgium, making the whole thing quite complex. But because of that, actually, we have built e-health foundation, which is extremely generic and scalable. And it's very much built around a federated architecture, where the central level only provides the basic services which guarantee a safe and secure data exchange, and which is connected with all the authentic data sources that you see below, which provide the data which are needed in order to support all the health data exchanges in the system. And then public authorities and other organizations in the system can develop the application they need. That's basically in a nutshell, how it works. And just as you can see here, that relies on a number of basic services which are available for all the developers in the system, and which are used either only one, but sometimes many of them are used all together. And as you see, one of the very important elements is the coordination also of electronic sub-processes. And I will come back to that in my presentation. Just to see how it works, basically everything works in terms of data sharing in Belgium through a so-called hubs and mid-hub infrastructure. So we have 5 different hubs which connects all the healthcare institutions in the system. So it's not only necessarily one per region. You can have more than one, especially in Flanders, where you have 3. And actually, we have only centrally, we have almost nothing. Only the information in which hub you have an information for a patient, one or more. But then each hub asks just the meta hub, where can I find, in which hub can I find information, and then you retrieve the information and you have a virtualized visualization of all the data of the shared health data records. Now, for the primary care, obviously they are not connected 24 hours, so they cannot work like that. So they are storing the needed information in safes, which are under the management of healthcare providers called in non-profit gathered in non-profit organizations. You have at least one per region, but you have also safes sometimes for specific applications like e-prescription, for example, which is also under the management of healthcare providers. How do we look at medication? Actually, that was a very central point very early in the process when we designed the first e-health roadmap in 2013. E-prescription was very much the key priority. But in the second version, and that's already the second version in 2015, it appeared already in no less than 7 action points. And this really becoming a highly strategic point for everybody. And actually, for different reasons, and also because of the complexity of Belgium, where everybody has the capacity to take new initiatives, we have seen not one, but several projects built around medicine. The first one historically was the SUMER, or the patient summary, which is today managed and controlled by the GPs, where which contains indeed the active medication. Uh, but, for example, the pharmacist, very early in the process, also decided to have their own shared pharmaceutical record completely under their control. And I must say that from their perspective, that was also strategic. They absolutely wanted to give the pharmacist a role in the system, which would just not be the one of a merchant, but also somebody who would take an active part in the management of healthcare record. And in order to do that, they wanted to make sure that they would control part of those data. And then you have the prescription system with controlled by the healthcare provider, the Recipe system, as you see it on the bottom left, which is there only meant to store the prescription, the digital prescriptions sent by all the prescribers in the system. And finally, you have this Vitalink here. And as I said, in Flanders, there was early in the process there was a consensus from the primary care actor that they wanted a more structured and more integrated way to deal with medicine. So the public authorities in Flanders decided to go ahead with already a medication schema, which would be accessible to all the primary healthcare actors and to the patients. So they were the first ones to do that. So we had all those projects working in parallel. And then we had another one, which is really critical for the shared medical record. That's a public investment and very big one, the so-called SAM, so source, authentic source for medicines, which is actually the only source today used by all the clients in Belgium, the EHR clients, but also apps for patients or whatsoever. And you have there, this source is actually fed by different authorities, the ones responsible for reimbursement, the one responsible for authorization, and you have also a number of other kind of data provided, linked to, for example, to evidence medicine. So we have an integrated source which serves all the clients. That's very important because it provides already a very high level of interoperability in the system at the very start. So when we came up recently with the third already iteration of the Belgian roadmap, as you can see, the whole roadmap has been restructured, and actually people were then ready to say, wow, now we need to go further. And here under cluster 4, you see again the medication record, which comes very strongly, but where people say, well, we need to find a way to go much further and to integrate it, to integrate now the question of quality of care much more clearer in the in a much clearer way in the process. And although there are 44 projects now included, as you see, there's a new one, that's the 4.4, which is VIDIS, which came into the picture. And VIDIS stands for Virtual Integrated Drug Information System. And it's not yet fully implemented, but it's ongoing, actually. And it was planned since this already the second iteration of the roadmap. And well, we had hoped to be already fully operational in 2018, but it proved a bit more difficult than we thought. So it's now implemented in phases, but it's pretty well on the road, as you will see. So what this roadmap first said, we need first to have a medication schema which is fully deployed everywhere. And that's actually, that's not only the medication schema, that were all the exchange of the projects linked to exchange of medicines. So that was also the transmission of medication transmuros, where we had to define how it would take place and which which kind of structuration of data, and also, for example, the normalized transmission between rest homes and pharmacies. So all those ones had to be fully deployed, and then we would start with this integrated communication systems. We really wanted first that the so-called medication schema would first, that concept would be first well understood by all the key actors. And that's basically, as you can see on the right, a medications list plus an administration schema. So which gives the posology, the duration, the indication, allows for checkups by the actors, and provides an indication of who are the orders, basically. There's now this medication schema is finally deployed in all regions, and they are stored in the safes that I described a bit earlier in my presentation, and it is stored in the safe of the region where the citizen is living. In order to reach that, in Belgium, we have a methodology now which is pretty well established that we're using for all the new applications that we will develop. We developed the cookbooks. We organized mini labs with all the industry players who need to implement this, and we integrate then when it's ready. We integrate the application in the national incentivization package, and in particular the GP software's incentivization package. And actually, the system that we have in place is that we actually paying the users to use certified solution. We are not paying directly the industry. So with this, we want to go further on the road. We want to have an integrated system which also deal with, for example, the link between the ambulatory sector and the hospital environment, but also which integrates the patient, his family, and of course integrates also all the actors of the primary care sector. It's a very dynamic medication plan, which can be consulted and used by all actors, but can be updated by all the actors for all the classical acts, as you can see, prescribing, dispensing, reimbursement, and administration, and can help the patient in the correct intake of medication. So if we look at the different components, we have a medication schema, we have the delivered medicine, we have all the authorization process when this is so required by the system, and we have the journal, which is basically a communication tool within the system. That's the four main components in it, which compose then the shared medication records. It's not a new IT system, it's a new shared instrument, just based on a virtual integration in which we'll manage all the data history, and we will have defined altogether quality control and business rules which have been agreed by all the actors in the system. So we don't try to make a fully new system, but we integrate all the existing systems, and the existing systems had to become widely deployed in order to do it. So if we look at how it works without orchestration, we see that actually each software is using data coming from the central database, and is only for its own purpose, producing data. In the exchange with orchestration, we have then here a different situation, because we are here providing data to different systems. So all the systems are actually contributing to the integrated vision of the shared medication record, thus with the information for the patient, the medication view, the medication review, just all the classical processes that you need, but then making it possible to have to deal with this objective of quality of care processes. And there's also the interdisciplinary care discussions. So just very clearly here, as I said, the idea is to optimize also the data quality based on the standards and the authentic sources, Again, same system, cookbooks, instructions, guidelines, business rules, which have been discussed, a methodology for the testing and the validation. And we start with what's existing, but the idea is to have globally all the rights of access aligned progressively. So we started that here you see again how we discussed with all the stakeholders, what do we want to keep on doing, do differently, do extra, and share digitally. There is no top-down obligation for all the actors. So it's a possibility which has been offered since 2019, and we thought it was really important to start with pilot domains and test end-to-end of partner systems and adapted softwares, or accept to make this effort in order to fine-tune and make the proof of the added value of this innovative manner to manage these patient medications. There were a number of conditions, of course, to do that, so that the medication schema should have already been implemented, for example, and we need, of course, a strong involvement of the patient and the informal care helper, for example, and they all need to, of course, to work within a context of integrated care, which is not taken for granted in the Bismarckian health system. So we chose a residential care domain, hospital sector, and integrated care project as the first domains where we tested it. And as you can see here, the idea is to use this medication folder as the main support for all the classical actions, the classical process, which were usually done in silos. In practice, that means that we will work on we are working in three phases. First, working on the consolidation view, the medication record. Then in the second phase, we are more focusing on the management of the medication, the link to treatment. And finally, in the phase 3, that's history management and processes. Sorry, there is a little edit problem there. And once again, we always with the same receipts. So developing the cookbook, first in the test environment, then we have the global cookbook published, then we work on the connectors, and then governance rules and requirements. Just in a very, I'm just finishing now quickly, if you allow me, Jana. So in the phase 1 here, just for everybody to understand what is meant is that we have a medication folder which can be consulted in the software or information system of the care provider and in the personal health view of the patient. So we don't change first in this first phase the way that the data access are managed in the current MetaHub system. It will come in the second phase. So it's an initial step to work, as I explained, to rework the classical process and to begin to explain what can be the advantages of this for the quality of care processes here. The second phase here, the big change, and it's ongoing for the time being, is that medicines are prescribed as treatment instead of package. So there is this new elements which is coming up in the here the management process becomes the very central part of it, we have new communication about the modifications in the medication schema by means of orders, which are kind of new prescription types in this system. For example, when an existing treatment is changed, stopped, prolonged, suspended, or an existing medication line is then selected and changed, so that you have a very clear understanding of what has been done and why. And as I said, for example, here the accent is put on treatment, where we will have an identifier for treatment, so that, for example, a chronic treatment can be dispensed by multiple pharmacists during the period until the following checkup. And finally, this in the last phase, we will have the medication folder will also allow to have a consultation of the history of the treatment and to support the medication review and the interdisciplinary care case discussions. So conclusions, the vision of an integrated shared medication records need to be taken in consideration as early as possible in the national roadmap. We pilot implementation, but with a clear methodology. So not just a pilot, you need to know what you do with the pilot to make it structured, to make it really implemented for the whole country afterwards. But that makes the concept attractive, and also that's a good way to engage with the industry. But if you have too many projects which are starting in the same time, you need to know that, of course, it's legacies that you need to deal with. So that can somewhat complexify a little bit the problem. The problem. So the better the vision, the best it will be. And finally, industry actually has been following without too much problem. The only thing they ask is a clear planning and acceptable timelines for the implementation. As long what they want is clarity and on what needs to be done, and they need a clear process for the testing and the compliance environment. And that will be it for me.
Thank you,